stranger to us. We would have met him in many different circles because he has worn many different hats. So, Dr. Francis Williams is a family medicine consultant who completed his medical training at the UWI Mona in 1998 and has held the distinction of being the very first graduate to complete the Doctor of Medicine degree in family medicine through the Bahamas campus all the way back in 2007. Currently, Dr. Williams holds the position of our medical chief of staff, and you would have previously remembered him from this role as the director of CME. But as stated before, Dr. Williams have had many different roles, such as being the vice president of the Bahamas Doctors Union, the president of the Bahamas Doctors Union, and he also served in various chairmanships throughout his career. So without further ado, I would like to welcome our medical chief of staff as he presents to us on this very important topic, medical errors and how to minimize or avoid. Dr. Williams.
Thank you so much, and good morning, everyone. Can you hear me? Hello?
Yes, we can hear you. We can hear you.
Thank you so much. So it's a pleasure for me to be here this morning. This is a very important topic, and I will be presenting on medical errors. So here we go. So medical errors represent a serious public health problem and pose a clear and present danger to patient safety. Medical errors can really occur anywhere in our healthcare system. It can occur in our hospitals, in the clinics, surgery centers, doctors' offices, old age homes, even in a patient's home. So medical errors can involve medications, surgery, diagnoses, equipment, or lab reports. So we're just going to start off with a lighthearted pretest. And this question is related to some statistics from 2013. So in your opinion, are medical errors the leading cause of death in the United States? Are they the second leading cause of death, the third leading cause of death, or not a leading cause of death at all? Just want you to think about that. I don't know if you've heard, but what is a never event? Is a never event an event that never happened? An event that should never happen? An event that will never happen? A medical error that is insignificant? Again, just for you to ponder. Final pretest. How confident are you in identifying a medical error? Are you not confident? Somewhat confident, confident, or very confident? So let's get into the meat of the matter. We will define what medical errors are and how they are classified. Then we will look into the prevalence of medical errors, looking at the statistics and causes behind them. Then we will look at different types of medical errors that can occur and their consequences. We will also investigate the cost of medical errors, both in terms of financial expenses and human suffering. Finally, we will examine the corrective measures that are being taken to reduce medical errors and their impact on patients and clinicians. Hopefully, by the end of this presentation, you will have a better understanding of medical errors and the importance of preventing them. So different people have different definitions of what a medical error may be. Medical error may be an unintended medical act, an act that does not achieve its intended outcome. The failure of planned action to be completed as intended. The use of a wrong plan to achieve an aim. a deviation from the process of care that may or may not cause harm to the patient, or a preventable adverse event that results from inappropriate medical management. We can classify medical errors in different levels of severity. There are 6 levels. Level 1, an event occurred that resulted in the need for increased patient assessments, but no change in vital signs and no patient harm. Level 2, an event occurred that resulted in the need for treatment and/or intervention and caused temporary patient harm. Level 3, an event occurred that resulted in initial or prolonged hospitalization and caused temporary harm. Level 4, an event occurred that resulted in permanent patient harm or near-death event, such as anaphylaxis. Level 5, any set of circumstances exclusive of the disease or condition in which the patient is being treated, which significantly increases the likelihood of a serious adverse outcome. And the worst of them all, level 6, an event that occurred that results in the patient's death. So, in 2013, the CDC estimated that out of the top 10 causes of death, medical errors fell at number 3. Medical errors were the 3rd leading cause of death, according to the CDC study in 2013, of over 250,000 persons in the United States in 1 year's time died from medical errors. Can you imagine? That's more than the Bahamian, half of the Bahamian population dead in 1 year from medical errors. So, medical errors, we know, are quite prevalent, cause hundreds of thousands of deaths, and they result in increased hospital stays, readmissions, and cause. So medical errors are a significant issue worldwide and can occur at any stage of the process of healthcare. They are responsible for a high rate of adverse events and patient morbidity and mortality. Factors that contribute to the occurrence of medical errors include poor communication, lack of training, inadequate staffing, and overwork, to name a few. Preventative measures such as comprehensive training programs, checklists, and standard operating procedures can help to reduce the occurrence of medical errors. Reducing the occurrence of medical errors will improve patient safety and satisfaction, while also reducing healthcare costs and improving the quality of care. So medical errors can take many different forms. We will look at medication errors, surgical errors, diagnostic errors, infection-related errors, communication errors, and administrative errors. So one of the most common types of medical errors is a medication error. Medication errors occur when patients are given the wrong medication or dosage, or when medications are administered improperly. They can have serious consequences, including adverse drug reactions, overdoses, and even death. Causes of medication errors include look-alike and sound-alike medications, illegible handwriting, and unfortunately, I have to say an amen there, but I'm working on it. Incomplete medication histories and communication breakdowns between healthcare providers. To prevent medication errors, healthcare organizations use a variety of strategies, such as implementing electronic medication administration records, standardizing medication labeling, and providing staff education. Surgical errors are preventable mistakes made during surgery. They can occur during any type of surgery, including elective and emergency procedures. Surgical errors can be caused by a variety of factors, including miscommunication, fatigue, inadequate training, and equipment failure. Examples of surgical errors include operating on the wrong site, leaving surgical instruments inside a patient, and performing the wrong procedure. These errors can have serious consequences for patients, including physical harm, emotional distress, and financial burden. Healthcare providers must work together to identify and prevent surgical errors. Diagnostic errors can occur when a patient is misdiagnosed or when a diagnosis is delayed. And they can be caused by a variety of factors. You know, as I was writing a report last week, it just so happens that I was reading a patient's notes to see that a patient had been stated to have X-rays that were normal. And in writing the report, I then had to go and get a report written on the X-ray. And what did I find? I found that there was a fracture of a certain part of the body, this undisplaced. And so, you know, unfortunately, these things are alive and present in the institution. Medical procedures and treatments can introduce bacteria and other microorganisms into patients' bodies, which can lead to infections. While some infections are inevitable, others can be prevented through appropriate infection control measures. Hand hygiene, sterilization, and disinfection are important aspects of infection control. Even the part of the body we use for certain procedures may determine whether infections increase. So as healthcare providers, we need to be trained to follow proper protocols. Our infection prevention and control unit is critical in helping this institution in decreasing our burden of nosocomial infections. Communication errors can lead to serious consequences. Miscommunication among healthcare providers or between providers and patients can result in medication errors, patient harm, or even death. Inadequate or incorrect documentation can also lead to errors in care and incorrect treatment. It is important for all of us to promote effective communication at all times. We should not have consultants not talking to junior staff and vice versa, or nurses not talking to physicians and vice versa. Administrative errors can occur at any stage of healthcare process, from scheduling appointments to billing. One type of administrative error is incorrect patient information, including errors in patient identification, such as administering medications or treatment to wrong patients. Inadequate documentation, again, such as incomplete medical histories or missing test results, can also lead to administrative errors. And these errors can have serious consequences for patients, such as delayed treatment or misdiagnosis. Preventing administrative errors requires attention to detail. clear communication, and a strong culture of safety. So this is just another slide looking in another way of medical errors. And I'm sure that you realize some of these things but may never have given it some thought. So, medical errors that change the standard of care. We can learn a lot from our painful mistakes. Studying these mistakes and learning how to prevent, monitor, and respond to them, however, has changed the standard of care. We all know that sometimes good things come from bad. And even after a hurricane, the sun comes out. So in 1976, Dr. Jim Steiner, an orthopedic surgeon, crashed his small plane into a field in Nebraska, sustaining injuries. His wife was killed, and 3 of their 4 children were critically injured. At the local hospital, the care that he had and his children received were grossly inadequate, even by the standards in those days. His family tragedy and the medical mistakes that followed gave birth to Advanced Trauma Life Support, ATLS, which many of our physicians in this institution do today. And that changed the standard of care in the first hour after trauma. Judy was a 39-year-old when she went to hospital for a hysterectomy, which should just be a simple in and out procedure. After she died on the operating table, the autopsy revealed that the anesthetologist had placed the endotracheal tube in her esophagus, not her trachea. The American Society of Anesthesiologists responded with a program to standardize anesthesia care and patient monitoring, and in 1985 created the Anesthesia Patient Safety Foundation. Standard practices now include the use of pulse oximetry and end-tidal carbon dioxide monitoring for anesthetized patients. The push for electronic monitoring systems for patients under anesthesia caused anesthesia-related deaths to plummet from about 1 in 10,000 to 1 in 200,000 in less than a 2-year span. Fatal allergies. As a young child, Betty had been given penicillin, and she turned blue and was rushed to the hospital and did well. But at 15, she got a strep throat, was given penicillin again, and died. No one asks about her medication allergies. Strategies to address the problem include adding physical prompts in consistent and prominent locations listing patient allergies, eliminating the need for the practice of writing drug allergies on just a bracelet, and also making the allergy reaction selection in the EMR a mandatory entry in the organization's order entry system. Wrong side amputation. So Bill had a seizure and crashed his car into a tree, crushing both his legs. Arteriography revealed that his right leg was salvageable, but his left leg was not. Unfortunately, the X-ray technician mislabeled the films, mixing left for right, and the orthopedic surgeon first amputated Bill's right leg. Preventing wrong site surgery became one of the main safety goals of the Joint Commission for accreditation of healthcare organizations. Establishing protocols became an accreditation requirement for hospitals, ambulatory surgery centers, and office-based surgery sites. So Frank was a 72-year-old when he broke his right leg in a car accident and had to recover for a few weeks in a rehabilitation facility. The nurses didn't know the patients needed to be moved regularly at that time, and Frank developed deep pressure ulcers. And when they became infected, Frank's leg had to be amputated. Nursing homes and hospitals now have programs to avoid development of bed sores by using a set time framework to reduce pressures and having dry sheets by using catheters or impermeable dressings. Pressure sifting on a regular basis and the use of pressure distributive mattresses are now common practices. Sponge counts. So Tom was 12 years old when his appendix ruptured and was taken to the hospital. 3 days after the appendectomy, he developed another high fever. 1 week later, the surgeon performed a second procedure and found that a surgical sponge had been left inside. Post-operative sponge and instrument counts have been routine for decades now, since then. There's no single standard, although nursing and surgical organizations have developed best practices for sponge needle and instrument counts. So, medical errors are not only harmful to patients, but they also have a significant financial cost. Medical errors can result in increased healthcare costs through additional medical care, follow-up, appointments, and longer hospital stays. Loss of productivity is seen in both patients and healthcare providers, leading to additional healthcare costs and delays in recovery. Medical errors can result in legal fees and settlements, particularly in cases of medical malpractice or negligence, leading to significant financial costs for healthcare providers. Medical malpractice, especially with litigation, can be very costly and can damage the reputation of healthcare facilities. Best practices and effective communication between staff can help prevent medical errors and legal issues. So let's take a look at PHA legal matters. Now, since 2021, the legal department of PHA has paid settlements for legal matters that could not be defended in excess of $7 million. There appears to be maybe some improvement so far in 2024, but certainly we are spending far, far too much on things that we cannot defend. When we look at the different facilities in PHA and litigation, there are 150 active cases going on today. 115 in PMH, in Grand Bahama 25, and at SRC 10. The main departments involved are surgery, O&G, NICU, but even though I have listed these as the main departments, this in no way suggests that other departments are not, unfortunately, integrally involved in these legal matters. Why do people sue physicians? Well, they sue physicians because there's failure to diagnose, most commonly. Patient suffered an abnormal injury, failure to treat, and failure to treat properly, poor documentation of patient instruction and education of the patient, errors in medication administration, failure to follow safety procedures, and improperly obtaining a patient's consent. So medical errors can have far-reaching implications for patients, for families, for healthcare providers. They can result in physical harm, such as infections, medication errors, as already stated, surgical errors, misdiagnosis. Emotional distress to the patient and families, such as anxiety, depression, anger, or grief, are not uncommon. And there may be loss of trust in the healthcare system. Addressing medical errors requires a multifaceted approach that involves us, the providers, patients, and policymakers. Error reporting systems are used to identify and report medical errors, which can help healthcare providers identify and address systemic issues that contribute to medical errors. Quality improvement initiatives focus on improving the quality of care delivered by healthcare providers, which can help reduce medical errors and improve patient outcomes. Patient safety programs aim to improve patient safety and reduce the risk of medical errors by promoting a culture of safety within healthcare organizations. Of course, technology can play a crucial role in preventing medical errors. Quality improvement initiatives focus on improving the quality of patient care delivered by the providers, which can help reduce errors and improve outcomes. Patient safety programs aim to improve patient safety and reduce the risk of medical errors by promoting a culture of safety with healthcare organizations. At PMH, we have a quality and patient safety department. And there is a post, a vacancy for a physician director of quality that has been vacant for a number of years. So I certainly wish that some of the consultants who may be listening would apply for that directorship. We need a director of quality. Technology can play a crucial role in preventing medical errors, such as computerized physician order health records, electronic health records, and medication barcoding. These technologies promote and accuracy in patient diagnosis and treatment by providing clinicians with vital information about patients, medication dosages, and allergies. They also help to reduce errors by automating processes, providing decision support, and flagging potential errors before they occur. Systems allow physicians to order medications, tests, and procedures in real time, reducing the risk of errors due to illegible handwriting or miscommunication. EMRs provide a complete record of patient medical record history, enabling physicians to identify potential risk and make informed decisions about treatment. Medication barcoding helps to prevent errors by ensuring that the right medication is given to the right patient at the right time. These technologies have the potential to greatly reduce medical errors and improve patient outcomes. Medical errors can also have a profound impact on healthcare providers. They can cause emotional distress, causing anxiety, depression, and other mental health problems. Work-related stress can be a significant contributor to these issues. And you know that there have been physicians in certain places that have taken, and you know that there are physicians who have taken severe measures upon themselves and done harm to themselves for some of these reasons. Loss of confidence leading to self-doubt, second guessing, and even early retirement for some healthcare providers. And then there's the culture of blame that also contributes, and to negativity in the healthcare organization, which can lead to scapegoating of clinicians, bullying, and other forms of unprofessional behavior. The impact of patients of errors include physical harm, which may include wrong site surgery, medication errors, misdiagnosis, and infections leading to hospital stays longer than usual, physical disability, or even death. Emotional distress, which may lead to anxiety of the patient, depression, post-traumatic stress, disorder, and a loss of confidence in the healthcare system. Again, loss of trust in the healthcare system can lead to resulting in patient avoiding medical care, seeking alternative treatments, or even filing lawsuits which further undermine the quality of healthcare. Patient involvement in the healthcare process is essential for improving patient safety. Patients are a valuable resource for identifying medical errors and can provide feedback on ways to improve patient safety. By involving patients in the process of preventing medical errors, healthcare providers can gain valuable insights and improve the quality of care they provide. Unfortunately, some of us believe that we are the ones who have spent 10+ years studying, so we ignore the patients, the same patients that we had to treat. But the truth is that they should know what is happening with themselves, how they're feeling, what they are observing. We need to listen to the patients. So medical errors, as stated, affect not only patients, families, healthcare providers, and the healthcare system as a whole. What is our ethical responsibility as physicians and clinicians to medical errors? We have an ethical responsibility to prevent medical errors, which can cause harm and emotional distress to patients. Physicians must take corrective measures to reduce medical errors and improve patient safety. We swear an oath to do no harm. And when medical errors occur, they cause harm. So, as I'm approaching the end now, there are certain terms that you should know. A never event. A never event is when a medical error should never happen. There are certain errors that just should not happen. And some examples include operating on the wrong limb or the wrong patient. Food meant to go in the stomach goes in the chest tube. Air bubbles go into IV catheters, resulting in strokes and/or death. Sponges, wipes, and even scissors are left in people's bodies after surgeries. These are some examples of never events. So, a sentinel event. A sentinel event is an unanticipated event resulting in death or serious physical or psychological injury to a patient or patients, not related to the natural cause of the patient's illness. And when a sentinel event is identified, the chair of the department or the unit head needs to come into action right away. They should come into action right away. There should be reporting and notification, investigation and review should happen, and there should be an action plan and monitoring that comes out of this. So, I don't know if you like holy cheese or not, but there are a lot of holes in this cheese. And this is showing that when there are holes in reasonable defenses, patients get harmed. We should follow proper protocols. But when we don't, the patient gets harmed. When we are given or forced to use faulty equipment, patients get harmed. When we neglect to share or document information, patients get harmed. When we fail to communicate with each other, patients get harmed. When there's inadequate supervision, patients get harmed. We need to plug these holes. It is not acceptable for patients to be harmed by a healthcare system that is there to offer healing and comfort. There is no one single solution to this ongoing problem, but rather many solutions and systems that must be in place and working properly to decrease the risk of medical errors. Our focus should not be on blaming, though, individuals, but on learning from the past and preventing future errors. So in conclusion, reducing medical errors requires a collaborative effort from healthcare professionals, patients, healthcare organizations, and in our little country in the Bahamas is highly reliant on support from government, especially in a financial way. By working together, we can improve patient safety and the quality of care. Medical errors are a preventable problem that requires a multidisciplinary approach to address it. By understanding the causes and consequences of medical errors, we can work together to reduce their occurrence and improve the quality of care. Let's work together to make healthcare safer for everyone. These are my references. I hope that we know that medical errors, whether it's the first, second, or third leading causes of death, occur too much. And as the CDC showed in the 2013 study, there were significant deaths. There are deaths that occur in the Bahamas as well. And so we need to do our best to prevent them. I'm sure we know what a never event is now. And I am hopeful that your appreciation of medical errors is now more than it was than when I started. I'm open for questions, answers, comments.
Thank you. Thank you so much, Dr. Williams. That was a very comprehensive presentation. You provided such a wealth of knowledge, a very timely topic, something that we as physicians should always have at the fore of our minds. Thank you for reiterating to us a lot of information that we may have known before, and for providing us with new information that we may have not. So I am seeing that the chat is becoming quite active. So we're just going to read through some of them very quickly. And as we go through this process, I would like to encourage everyone to please fill out the feedback that has been placed in the chat. This is accredited CME. So in order to collect your CME points, we need you to fill out that form as soon as possible. Please be sure to sign in with the name that should be reflected on your BMC certificate. Okay, so we have, thank you, Dr. Williams, excellent presentation. This is always a timely topic which needs to be addressed frequently. Quickly addressing errors and involving the family as soon as possible results in better relationships with the family. Dr. Griffith-Bowe agreed, policies and protocols are essential to aid in the recognition and prevention. Dr. Varunda, thank you, Dr. Williams. Dr. Carroll says, good morning. Thank you, Dr. Williams, for an excellent presentation, which underscores the importance of effective communication among all levels of staff. Are there plans for workshops to this end? Dr. Williams, are there any plans?
Certainly, that is something that we as an institution, administration, need to consider. I think that we can all learn from each other, and we can certainly find out from persons who may be hesitant, because I'm sure that there's a great hesitancy in many people in reporting errors. In the research, many persons waited 5-10 years to disclose that they had seen or were exposed to medical errors. So workshops certainly can be helpful in us providing an avenue for people to discuss their concerns going forward.
Thank you. We will look forward to that. Dr. Phyllis Darville, thank you, Dr. Williams, for this very informative presentation. Dr. Varunda would like you to please explain the protocol that we follow at PMHPHA.
Yes, I think I saw the end of a question. So that has to do with how do we tell persons that medical errors have occurred? So what is the protocol? Well, if you know that if you know that an error has occurred, one should certainly report it to the person who is higher than you are. Ideally, the consultant is the one who is in charge of the team. And so if there's an error, report it to the consultant. so that whatever needs to be done to mitigate the effects can be done. Communication errors are always going to occur. When we fail to communicate, we run into more problems. And so report it to your consultant. Your consultant can report it to the chief, the chair, and so we can deal with it adequately. And there are risks. There's a risk report that when or an incident report, that when a problem, an error occurs, that a report should be written and it should be investigated.
Okay, thank you for that. And Dr. Sinqui says, comprehensive and helpful overview. Definitely a need for quality review and a willingness to improve. So lots of lovely comments and questions. Oh, Dr. Pinda Butler says, good morning. Thank you for an informative presentation on a very important topic. It's a very important topic indeed. And we thank you for raising this topic with us. By way of additional announcements, some people are trying to first me, but we're going to do it now. I recognize your hands. That's Doris Swain. I'll come to you shortly, but since I've already started, I'm just going to complete the thought. By way of additional announcements, I just want you to know just how special you all are and just how committed MCOS is, because on his birthday, he continued his commitment to the education of our physician population and came and presented this very important topic to us. That's right. Today is Dr. Williams's birthday. And so I want as many of you who are able to just open your mics on the count of 3. We have to try and do it in unison so that we can say a very big, special happy birthday to our MCOS. Okay, let's get ready now. We got to be coordinated here. 1, 2, 3.
Happy
Happy birthday!
Happy birthday!
Well,
Happy birthday!
Thank
Doing
you
joy.
so much.
Birthday, Dr. Williams.
Happy
Thank you so much.
birthday!
Thank you.
Excellent.
Yeah.
Happy
They
birthday,
just
Dr. Williams. We pray that God continue to bless you. And we cannot thank you enough for sharing a part of your birthday with us. We do feel very special, privileged, and honored to share it with you. And as you would see, many happy birthday greetings coming through in the chat just for you. I hope it makes you feel extra special today. Additionally, I would like to send special shout outs to our emergency medicine physicians who are celebrating Emergency Medicine Week. Congratulations, guys. You work very hard and we truly appreciate you. And of course, I cannot forget the celebrations that have been occurring all month long with the nurses. Happy Nurses Month. We do appreciate you. And of course, the family medicine specialists, of which I am privileged to be a part of that group, we celebrated during the week of May 13th to 19th, with our culmination being on World Family Doctors Day, which was celebrated on May 19th. Ms. Swain, you had a question?
Yes, good morning. Good morning to all. Happy birthday again, Dr. Williams. I want to commend you for an excellent presentation. I just did a course on health policy at the UWI, and one of the things we addressed was adverse events. And I think in our institution, it's referred to as documentation errors. And so with that being said, when we have an adverse event or a medical error, I think that's included in adverse events, what are the courses of action that we take in our hospital to prevent medical errors? Thank you very much. I'll shut my mic and listen.
Yes, thank you, Sister Swain. So certainly, as I suggested, there are incident reports that should be written, and the errors should be brought to the attention of the hierarchy within the teams. Depending on the level of error, that may determine the action that is taken. So certainly level 1 to 2, where there's very little impact, simple discussions may be made. Different departments do things differently. And so, for example, in the surgical department, they would have weekly morbidity and mortality rounds where they openly discuss management of patients with the attempt to identify things that did not go well and things that went well and how to improve. So there are different ways that medical errors, adverse events are dealt with. Sometimes disciplinary action must occur, many times not. But the end goal is, as suggested, to improve patient outcomes. And so reports, education meetings once the Sentinel event has been investigated. If it reaches that, the report is written and it should be shared with all persons within that area where the adverse event would have occurred.
Thank you so much. Appreciate it. And that's incident reporting and documentation. Thank you, Dr. Williams.
Thank you.
Dr. Williams, you have a few people who are calling for this to be an ongoing series event. You have people who are asking for Patient Safety Week or an all-day seminar. So you have opened the door for communication. Their population is very receptive. So we're very happy about that. And the last two things that I want to mention is, remember that Dr. Williams put out a challenge out there to us after such a very important topic. I hope that people are very excited about taking him up on the position of Director of Quality. That position is available. It's a director's position, and you can find out more information through the Office of the Medical Chief of Staff. Okay, just checking one more time. Okay, I'm seeing Jessica Edwards. Did you have a question? Dr. Edwards? Okay, it doesn't seem so. Please be reminded that our next CME session will occur the second Wednesday in June. That would be June 12th. And we look forward to see all of you there. So once again, please fill out your feedback. This is accredited CME. We are looking forward to being able to get those CME credits to you on a timely basis. So help us to help you. Once again, thank you so much for joining us for this very exciting and informative CME presentation. Thank you for being here. Thank you, Dr. Williams, for sharing a portion of your special day with us. You all have just leveled up on your knowledge, and I will see you next CME. Have a great day.
Good morning and thank you.